Welcome to one of the Cambridge Public Health seminars, and this one is particularly from the Ageing and Life course research pillar. I'm Carol Brain, I'm co-director of Cambridge Public Health, which is an interdisciplinary centre of the University of Cambridge, and it has its aim is to encourage interdisciplinary research across the university and beyond it with key stakeholders and partners and those who are interested in public health research in all its forms. We're very interested in research as well as teaching and training, capacity building, and for maximal impact from local to global. So do look up Cambridge Public Health. Our website isn't great at the moment, but it will be a lot better in the autumn. It's been under construction for some time. And those of you who are familiar with the Institute of Public Health, and I can see some folk who were here in earlier eras are here. Cambridge Public Health is the successor to the Institute of Public Health and the Public Health at Cambridge network. So bringing together that in a very interdisciplinary manner. So it's great to see you all, thank you. And particular thanks to our speakers today. So this aims to be a seminar sort of stimulating us to think about methods. And I think we've got quite a few methodologists on the call, which is really great. So I am very grateful to Adina and Sebastian. You have the abstract, which is, I'm sure, what piqued your interest to attend. And so just to introduce them, Sebastian is going to speak first and Adina second. They're both from Columbia, but they're from different departments, so which is great, which is exactly what Cambridge Public Health aims to foster as well. It's cross-disciplinary and cross-departmental and cross-school work. They're both assistant professors. And they are in the departments of health and policy and management and epidemiology at Columbia University, those two being separate, but working together. So they work on causal inference and particular methodologies. And we're going to hear both the methodology and the application, sorry, Adina, and the practical applications. And I know there are people in the audience who will be interested in both aspects of these. So I think this promises to be a very interesting seminar. And I'm hoping that we have lots of interesting questions afterwards. So without more ado, I am going to hand over. Adina, you're just going to kick off, and then you'll hand over to Sebastian.
Yeah, thank you so much, Carol, for the introduction, and thanks everyone for joining us today. So today I'm going to talk about an application of regression discontinuity designs to evaluate specifically the effects of statins on myocardial infarctions using electronic health data from the UK. So Sebastian here, he'll be introducing what is regression discontinuity design. I'm hoping, hearing about the mission of Cambridge Public Health, that it's a little bit of an overview of RDD. It has some teaching aspect to it, so hopefully that would be enjoyed by everyone here. But in brief, regression discontinuity is a method which allows you to estimate causal estimates or causal effects in observational settings. So overall, the purpose of our work and of our presentation today is kind of a proof of concept type of evidence that RDD could replicate known causal effects. So we want to know that, and we want to try to prove it. So I'll be presenting the application part, as Carol said, but first Sebastian, who will, to help you follow more with the application, he's going to present an overview of what RDD is. So I'm going to give it to Sebastian first.
Thanks, Adina. Thanks, Carol, and thanks everyone for being here. It's a pleasure for us to present in this seminar. So yes, as Adina said, I'm going to talk briefly about an introduction to RDD, which is an area that we have been working for some time now, mostly in methods, but also in several applications. This being one of the most recent ones, and I think more interesting. We have also some more future plans that Adina will also discuss later. So let me share with you my slides for today. So this is meant to be to provide mostly a practical guide to how to conduct RD analysis, but I will be happy to discuss more specific technical details if anyone is interested. So feel free to ask questions at any point. So let's start. As you might know, especially if you are here, that RD has received a lot of attention recently, particularly in social sciences, but more recently also in the medical field, even though with some still with some limitations, even though we see some more works being conducted every day. And so part of our goal is also make this more easier to implement for people. I mean, become more attractive. We think that it has many benefits compared, especially with either randomization studies or other non-experimental methods. And in particular, as I would like to show you today, how easy to implement this could be, and how it can generate more credible estimates compared to other non-experimental methods. We will show you today, in particular, a comparison with matching estimators. We can also mention that since usually we are going to rely on larger samples, another advantage is that we can explore heterogeneous effects. That's another important aspect of RD. But overall, I think that the credibility is a big aspect of why we think it's an important contribution to study causal effects. There are obviously some drawbacks, as usual. I want to mention a little bit of that today. Probably the main one is how the type of effects that we can recover is more of a local effect. So we have to keep that in mind when we interpret the results and when we, especially to compare among different studies. Also, as I will discuss briefly today, to generalize the model to some specific context might be challenging, and still some of these areas are not being developed yet. In particular, something that is important for us will be survival models and dynamic context. Right? So I will go over the standard model, discuss some extensions. In particular, I want to focus on these ones that are, I think, more relevant for us and more general for health-related studies. So I'm going to go with the methodological discussion, then Adina will go over, connect that with our application. Okay, and again, feel free to ask questions at any point. The structure of my presentation will be very simple. I'm going to go over a brief overview of what RD is. Then I'm going to talk about estimation and inference, the main aspect, and then I will discuss some extensions that go beside this main model. Okay, so overall, what we're trying to do here, as you know, we're trying to recover the causal effect of a policy or an intervention. What is specific about RD is that we can characterize the design or the implementation of the policy by the way that treatment is being assigned. So typically, we will have a score of or a running variable. So in our case, this will be the CVD risk score for the patients. And based on this score, treatment is going to be defined based on a known cutoff, right? So there is a rule such that everyone above this cutoff, in our case, it will be 20% risk score, will be eligible to or will be assigned to the treatment group. And everyone below that cutoff will be assigned to the control group, right? So what we have here in the ideal case, what we call the sharp RD model, is this abrupt change in the probability of treatment from 0 to 1, as I'm showing you here in this plot. And so the idea is that we can exploit that jump to recover a causal effects under certain assumptions, and that's what I'm going to discuss next. Okay, so a little bit more about the setup. Typically, we will be dealing with a random sample, and this is another nice feature of RD. We only need basically information on the score of each individual for each unit in our sample, the outcome, and based on that and the known cutoff, we know what type of treatment group people have been assigned to, right? So we're going to have two potential outcomes, Y1 and Y0. So the outcome that would have been realized under the treatment or the control. And what we are going to have then is, when you think about the average relationship between these potential outcomes and the score variable, what we have is these two red and blue lines that we have, right? We can expect to observe a relationship between, on average, between the outcomes and each treatment state and the score, but based on the specific design of RDs, we only observe the solid part of the line, right? So we observe this solid part for those who are assigned to the treatment group, and we observe this solid blue line for those who are assigned to the control group. Okay, so if we are interested in say, the average treatment effects, we would like to observe actually this line for everyone, right? And then we can take the difference, and then for each value of the score, we will have a measure of the effects of the treatment, right? But based on the way that, we only observe one potential outcome for each unit, and then we cannot have that the only hope for that to recover that difference is basically happening at the cutoff, right? Where we almost observe the two curves, right? The two solid lines. And that's basically what we are going to be using for the RD. The RD treatment effect, the parameter that they're going to be able to recover in RD is basically going to be the distance between the mean outcomes for the treatment and control groups at the cutoff, right? And that's basically you can already see the local aspect of this. We are not going to be able to say much about what happens in other areas above or beyond the cutoff, because we expect confounder to play a role, right? So in the case of the risk score, we wouldn't rely on comparing people with very high to very low risk scores and expect that to bring us a causal effect. But that's something that we could expect here at the cutoff. So first, I'm going to discuss under what assumptions we can recover that effect. Then I'm going to talk about how to estimate that and how to conduct inference on that. Okay, so this is then the idea, what we're trying to recover, right? So the average treatment effects at the cutoff, the expected value, the difference, the average difference between the two potential outcomes. The issue is that we don't observe this quantity, right? So most likely no one will, since typically this score is a continuous variable, we may have no one except in the cutoff, and even if we do, they are going to be assigned to either the treatment or the control group. So then the identification assumption here, how can we recover this parameter from the sample, is going to be based on a continuity type of assumption. The idea here is that we would like to expect that these two regression lines are going to cross the cutoff smoothly, right? So we don't expect them to jump, even though we don't observe what happens on the other side. So we expect this part to be a smooth continuation of what we observe, and this part the same. Okay. So under that assumption, what we can do is use the observations that we have close to the cutoff to approximate that quantity, right? So we're going to use individuals who are close to the cutoff in the treatment group to recover the first component of our parameter of interest, and we're going to use individuals who are close in the control group to recover the second part, right? So that's the two things that are observable, that we can use data to estimate, and that's how we recover, how we identify the parameter of interest, okay, based on this idea of continuity of the regression function. So now let me talk about estimation briefly. The most common approach in RD is based on local polynomial estimations. This is a non-parametric approach, so has that flexibility that doesn't rely on a specific functional form assumptions. We don't need to assume that these regression functions are either linear or they have a specific shape. They're going to just rely on the data to tell us something, and then they're going to model also the misspecification bias that we might have. And I'm going to talk a little bit more about how this works in practice, but it's very easy to implement. It basically works as a polynomial regression, and easily you can do that in software, statistical software that you use, but also there are several packages, some of which I work in, that will do this also automatically. So the idea is what we observe in real life is just data points for the treatment and the control group, right? So based on this, we want to estimate, remember, the values of the regression functions for the treatment and the control at the cutoff, right? So first things we want to do is to restrict our sample. So they're going to use this range of the data defined by the bandwidth, which is basically telling us how far from the cutoff we want to go. Then we restrict only the data, the analysis data to this range. We can ignore everything else, and I'm going to talk about how we choose this bandwidth. But in principle, the important thing for now is that we only will use these observations. We want to be local, we want to be close to the cutoff, because that way we expect basically individuals to be comparable and to avoid selection issues when we are trying to look at their differences, right? So once we have this sample, what we do is very simple. We simply fit a polynomial regression in this restricted sample, right? Typically, it will be a linear regression. So just reg yx on each side. We can do this either with interaction, so we do this everything in one step, or we can simply run separate regressions on the right and on the left of the cutoff. And based on the intercept of that regression, we get our estimates of the values of the regression function for the treatment and the control, and the difference between those two are going to give us our estimated RD effects. Okay. As I said, this is a non-parametric approximation, so there will be a bias. They're going to assume that we fit this is correctly specified, so they're going to deal with that later, but they're going to try to make that bias as small as possible. Okay, they're going to be trying to deal with that issue. And another important issue here is, and why local polynomials are popular in this context, is that if you notice, we are dealing with estimation at a boundary point, right? So when we estimate here the red line, we don't have observations on the left, right? And the same happens here. The opposite happens for the blue line. So we don't have observations on the right. So we always have to estimate based on the restricted type of analysis. So that could be tricky in some contexts, but local polynomials are particularly well fit. You can show that they have good properties when you're trying to estimate a regression function at a boundary point. All right, so this is just a summary of the methods, just a lot of the questions, but nothing really complicated about it. But what I wanted to show you is that a summary of what I said. This is the parameter of interest, right? So if the average treatment effects for individuals who are at the cutoff, right? So they're going to see estimate variety effect of the statins for those who have a risk score of 20% in our application. And this can be estimated simply by a difference between two OLS coefficients, which are coming from least square regressions. Usually, it's going to be weighted, right? So there is this kernel function who's going to weight observation. Typically, the closer they are to the cutoff, we provide more weight to those units because we think they are more representative of where we're going to recover. So that's one of the things we have to think about. The second one, it will be the order of the polynomial, right? We want to fit a straight line. We want to fit we want to use a linear fit, a quadratic, or higher order polynomials. That's the second choice. The final choice, the most important, is the bandwidth, right? So they're going to restrict these least square regressions to this range close to the cutoff and not using the entire sample. Okay, so then local polynomials are based on these three choices. And then the main part of the implementation is deciding on those, which I summarize here briefly in 3 steps, right? Typically, what you will do is start by specifying the polynomial order and the kernel. These are usually the easier choices because rarely they will affect your results, right? You can, for robustness, obviously you can check with a polynomial order higher than 1 or a different kernel. You can use just a uniform kernel that will be basically providing the same weights to all units. but for most cases, that's not gonna make a difference. The key choice is the bandwidth, right? Because depending on how many observations we take, that's gonna impact both estimation and inference. There are data-driven methods, right? So we don't choose this manually, typically, but we let our data decide on what is the right choice. And I'm going to talk next about that. But once we have those three options, we can easily construct our quasi-estimator just by running these least square regressions. And then inference part is a little bit more complicated, or at least we have to be a little bit more careful about it. So I'm also going to spend a few minutes going over that. Any questions before I continue?
So I'm just trying to open up my camera, but I don't see any hands up at this stage. It might be, although people might have questions about the analytical approaches, I imagine they probably weren't ready to ask you them now. So if you just press on, I think that's probably the way to go ahead.
Okay, yes, you can ask anytime, even later, maybe when we go through the application, some questions might arise in terms of the implementation. I will be happy to answer them. So this is one slide about the bandwidth choice. As I said, this is the critical implementation aspect that that RD requires. The most common approach is to use what is called the optimal mean square error bandwidth, which basically is the choice of the bandwidth that minimizes the MSE, the mean square error of our estimator. Right? If you remember maybe from some statistical class, the mean square error of an estimator is simply the sum of the bias, the square of the bias, and the variance, right? So these are two things that typically we want to reduce, either eliminate or at least reduce, and usually we have a trade-off between them, so we cannot get rid of both of them, but somehow we want to balance that. And so the idea will be to theoretically construct the MSE of our estimator. Since we know we have a formula, we can construct that. We know how the variance and we know how the bias looks for this estimator, and then we choose the bandwidth that will minimize that. We have a formula for it. It's this one that you can see here. You don't need to worry much about how it looks. This is all usually implemented in the software, but just to give you some intuition of how this works, what we have here is a first component that depends on P, which is the polynomial order, so that the bandwidth will adjust depending on how you want to model the regression function. And these two features of the data, which is the bias here in the denominator and the variance in the numerator, right? So depending on how much noise you have in your data, basically this optimal sample size will change, right? So, and the intuition here is that we have a trade, right, as usual. If we want to reduce the bias, what we can do is get a very small bandwidth, right? If we get very close to the point that we care about, most likely we're going to estimate it without the bias because the user observation is very close to the regression function. We cannot miss it that much. The problem is that by having few observations, they're going to increase a lot the variance, right? So the idea then is to balance these two things such that the sum of them is minimized, okay? And this is basically what this formula is telling us. We can estimate this variance and this bias, so they will give us a plug-in version of this estimator of this bandwidth that we can use then to conduct our local polynomial estimation in practice, okay? One thing that is important for what I'm going to talk next, which is inference, is the second part here. There is an n, right? So the sample size affects the bandwidth, and we have a negative coefficient here. So the idea here is that as is standard in non-parametric estimation, the assumption is that the expectation is that as the sample size increases, you're gonna get closer and closer to the point that you care about. In this case, you're gonna get closer and closer to the cutoff, and so we're gonna use a smaller bandwidth, right? So we have the larger the sample size, the more options we have to get closer, right? Because we would expect to have some observations close to the cutoff. And this coefficient here tells us how fast basically this bandwidth goes to zero, right? How much it gets smaller as the sample size increases. This is going to be important for the inference part, right? So we chose a particular option of these rates that will minimize the mean square error. Now, what happens with inference, right? So estimation, we are done. We have how to estimate the bandwidth. Once we have that, we use it. We choose a linear approximation and a triangular or a uniform kernel, and we get our RD effect, right? The tau hat that we have here. The question is, how do we do inference, right? So we could go the standard way. Once we have an estimator of the variance and a point estimator, right? We construct confidence intervals based on the test statistic, right? Assuming that this ratio here asymptotically has a normal 0-1 distribution, right? We can have the usual confidence interval where we have the point estimator plus minus, let's say, 1.96 times the standard error, right? So this is the usual way we conduct inference, and typically it works, right? This is what Stata will report when you run OLS, right? What is the problem here related to what I said about using a non-parametric approach and the role of the bandwidth? The issue here is that the bandwidth that we chose optimally for estimation is not going to give us the right solution for inference, right? It's not small enough to get rid of the bias for inference. And then what happens is that instead of this t statistic here having a normal 0-1 distribution, it has a bias. So it's kind of shifted towards one of the sides, and that's going to ruin our confidence intervals. The confidence intervals also are going to be centered at the wrong place, not at the parameter that we care about. Okay, because of, again, we are choosing the optimal bandwidth such with a rate that doesn't go to zero fast enough for inference. Okay. Typically, a solution for this people will do in practice is what is called to undersmooth, right? So instead of using this optimal bandwidth, you will use a smaller one, right? So an option, a rough option will be to cut it by half, right? Or take 3/4 of the optimal bandwidth, and that under the expectation that will give us the correct inference, right? So we can get rid of some of the bias. This is obviously very ad hoc. Typically, it's not going to be optimal. We may lose power because we are decreasing the sample size. So if you, just from looking at some quick simulations, you can see that this is not going to work well. So in earlier work I did with some colleagues, we proposed what we call a robust bias correction approach to conduct inference specifically for the RD case, although it applies also to local polynomials more in general, which basically is a method to construct confidence intervals, right? It's only focused on inference. We are not modifying the way that we conduct point estimation, but we propose a different way to construct the confidence intervals, which takes into account this issue with the bias, right? So what we are doing is we are doing some bias correction on the numerator here. So this tau now is the original estimator minus, so we're getting rid of the bias by estimating that thing that we already had to estimate anyways for the bandwidth, right? The second thing we do is we adjust also the variance. So the standard errors are going to account for the original estimator plus this second estimator here that is accounting for the bias correction, right? So typically they're going to be slightly larger, but that way they're going to be robust basically to a wider range of bandwidths. And that's basically what's going to allow these confidence intervals constructed in this way, where now we are recentering the point estimator and then adjusting the variance accordingly. They're going to have correct coverage, right? So let's say 95% coverage for more bandwidth than before. In particular, it's going to work for the MSE optimal bandwidth. So we can just use the same bandwidth for both point estimation and inference, and we are done. Okay, we have valid results. That's an important issue that also simplifies implementation. So that's kind of the quick summary. I added here just for you to have some sense of how this works in simulation. So the idea here is that when you look at coverage, right? So the empirical coverage of 95% confidence intervals, when you look at under smoothing, which is this red line here, we see that quickly as we increase the bandwidth, right, as we allow more bias to affect the estimator, we quickly lose coverage, right? We are moving away from correct coverage, which in this case should be 95%, because that bias is shifting the confidence intervals, and then we are not covering correctly the parameter of interest, right? And then the solid line is what happens with the robust bias correction that we propose, which basically is robust in the sense to different bandwidths, right? So not only to the MSC optimal bandwidth, but a wide range that is important in practice. Since we have to estimate all of these things, it's good that our results will be robust to the job. We have different ways of showing this, right? So for different bandwidths, combining we also show that interval length, right, is not affected by it. So they're going to be slightly longer, the confidence interval, but it's still informative of the result, and you gain this robustness here. And let me just skip this now. All right, so then let me just talk quickly about how can we extend this model. So far I talked about the basic RD specification, which is this sharp RD, in which implicitly we have been assuming that we have perfect compliance with treatment assignment, right? Everyone above the cutoff is assigned to treatment and takes the treatment, and everyone below it does not, okay? The most common case in practice, especially in medical studies, is to have some sort of non-compliance, right? So this will be what is called the fuzzy RD, right? So especially when you have guidelines, as in our case, you will expect that there is some discretion by the doctor or the patient to decide to take the treatment when they are allowed to do it, or not to take it, or also the same thing when they are supposed to be in the control group. So we can have the two-sided non-compliance. So there are two things we can do here. We can just ignore this feature, and then what we are estimating is not an average treatment effect, but it's what is called an intention to treat parameter, right? So it's basically the effect of being assigned to the treatment. That's the effect of being assigned to statins, but not to actually take it, right? That's a more difficult thing to recover now, given that the decision to take it or not implies certain endogeneity, right? It's not going to be random anymore who takes the treatment and who doesn't. But the typical solution here is closely connected to the IV literature, right? So we have this instrument which is being assigned to a treatment and control. We still think of people being on one side or the other of the cutoff as random, right? So especially for in particular for those close to the cutoff. So we can use that assignment as an IV to recover a local average treatment effect for the compliance, right? So the same way that that IV will work in a linear model, for example. So all what I said can be extended to that. That's very standard, and everything is also easily available in most software packages. So you can do that in practice. You just have to think about the amount of non-compliance and how to interpret this local effect now on the compliance, but everything else is the same. We still have a bandwidth, an optimal bandwidth. We still approximate this with a local polynomial and so on. A few more natural extensions to this that are relatively straightforward. Instead of looking at the level of the regression function, you can look at derivatives. In some contexts that might be relevant, this is what is called a kink RD, in case you might see this somewhere. It's basically, it can be implemented the same way that I just described. We just look at the different coefficient from the regression, from the least square regression. Sometimes we might have different multiple cutoff, right? So different treatments, for example, depending on the level of your risk score that you have, something like that. We can have multiple score variables, right? So treatment depends not only on the risk score, but some other health measure that doctors can use, and that's also something that can be analyzed, and there is work on that. That relates with geographic RD that even in the medical context sometimes is relevant, right? So we might want to see individuals who are close to each other, but in different regions that might have different insurance systems, coverage, and so on. So you can do something like this. You can add covariates, right? So a nice thing of RD is that in the standard specification, you don't need to have any information about covariates because you expect that individuals, by being close to the cutoff, they're going to be similar in observable and unobservable characteristics, and then you don't need to control for covariates really, but sometimes you have them, and so you want to use them. And so typically the goal here is, similarly as you will do with an experiment, is to improve efficiency, right? So you want to include them in the model to reduce the noise in your estimates, and that's something you can do. You can also look at heterogeneous effects, right? So you can see how the effects vary for particular subgroups and so on. And this is one of the things, again, this is also something that you can do easily in practice. Finally, the extension to survival analysis is something that we are using now in the paper we are presenting today. With some limitations, we are hoping to, we are planning to extend this model a little bit more to add more flexibility to it. But basically what we are doing here is based on the standard survival models that I'm sure you're all familiar with, right? We are trying to model here the time to a certain event, and we have data, we observe individuals, let's say patients, for some time, starting from, let's say, when they receive a treatment. And ideally, we'll see this, we will observe them until the event happens, but usually you may have that the study ends before that, or people withdraw, so you have all of those issues. One of the most popular models is the Cox proportional hazard model, where we have this baseline hazard function, and the effect of the covariates is proportional with this exponential function, right? So it all ends up, the goal here is to estimate this beta coefficient to measure the effect of the covariates. So what we do here is, in our paper, we're going to be using a version of the Cox model for RD. So this is what you have here, right? It's a straightforward extension to it. We're going to rely on the parametric specification of the Cox model. So they're going to have the proportional part and also the linear specification for variables that we use in the model. In this case, it's going to be the running variable that will have different effects on the left and on the right. This is what we are doing here today. But we are planning more extension of the model, basically to add more flexibility in a way, even though it's still going to be a proportional model, we want to be more flexible in the way that the running variable affects the hazard function, right? And this is something that hopefully we will have some results soon as well. Okay, and with that, I think I'm already a little bit past time, so I'm going to stop here and happy to answer any questions before Adina starts, but otherwise, all yours.
Thanks, Sebastian. I think in the interest of time, I think it might be good if Adina, if you carry straight on, and then I'll open it up afterwards, and when we can see how much time we've got.
Yeah, sounds good. I'll do that. Once, Sebastian, can you unshare screen? Perfect. Okay. All right. Okay. Do you all see it? Perfect. All right. So I'll begin a little bit with our motivation. I want to thank Sebastian for the overview on the method. Hopefully that will help me move faster when I get to the methods section. But I really want to first begin with the motivation for this work. I am particularly interested in really investigating the causal relationship between statin use and dementia. This is because statins are really widely used. For example, they're highly prescribed. For example, in the US, they're #2 drug that is prescribed. More than 39 million adults in the US that are 40 plus take statins. Also, there are a lot of hypothesized mechanisms through which statins may reduce the risk of dementia. So, statins are an effective treatment, for example, for hyperlipidemia, which if it's untreated, it's a major risk factor for dementia. Also, they exhibit anti-inflammatory properties, improve endothelial function, which are thought to kind of protect against stroke and other cardiovascular diseases, again, which are major risk factors for dementia. So in a way, developing a better understanding of that relationship could potentially help inform better interventions, public health interventions. However, it's important to note that currently exists mixed evidence on this research question. For example, RCTs have mostly found a null effect of the relationship between statins and dementia or cognitive decline. And here I give just two examples, PROSPER and HPS. PROSPER is the prospective study of pravastatin in the elderly at risk, and HPS is the heart protection study. Both of them, they found no difference in the prevalence of cognitive impairment or even the rate of cognitive decline over 4 to 5 years between people that took statin versus those that do not take statins. So those treated and untreated. On the other hand, when you think of observational studies, they have mostly shown protective effects. So it's the other way around. They have mostly shown protective effects. And there are a lot of studies, some evidence comes from, for example, the Rotterdam study, the Sacramento LA Latino study. Also, there was a recent meta-analysis of about 36 studies that showed a 20% reduced odds of dementia in that meta-analysis for those who are using statins versus not. Also, in 2012, at least in the US, the FDA, which is the Food and Drug Administration, actually issued a safety warning regarding potential cognitive and memory loss coming from statin use. So all of this together, this kind of mixed findings, for us, one of the suggested explanation for this inconsistent evidence when we think of RCTs versus observational studies is the non-exchangeability, which is perhaps not accounted for in observational settings. So in addition, while we think of RCTs as being the gold standard, a major drawback is that they are often underpowered and do not have enough of a sample size to be able to conduct inference across diverse groups of patients or people. So in an attempt to resolve some of those inconsistencies and discrepancies, really while moving toward more of an improved understanding of this research question, our ultimate goal is to answer this specific question: what is the causal effect of statin use on dementia in an observational setting and with no unmeasured confounding? This is the ultimate goal of this work that we are doing today. So why am I interested in regression discontinuity design? I won't say much about it because Sebastian gave a full lecture on it. But thinking more generally about why this method could be useful. So a common theme, as you know, in epidemiology and observational epidemiology is that no matter what adjustment methods you do, you might end up with this problem of unmeasured confounding, right? So despite that, we know that there are a select group of methods that could help with this issue. And one of them is regression discontinuity designs. So as you know by now, RD is a method that is going to compare the outcome of individuals who are just above and below the cutoff. And that just is very important, right? So they're like right above and right below the cutoff. And that cutoff is a specific threshold that recommends treatment, right? And so we use that creates this kind of natural experiment in a way, and allows us to investigate causal relationships. So while being a quasi-experiment and with RD having its conceptual underpinnings in an RCT, RD also capitalizes on a lot of advantages of observational data, whether it's long follow-up time or whether it's more diverse samples. So it allows us to use those advantages from observational studies. And this schematic is just to kind of show you that idea, right? That quasi-experimental studies are kind of bridging between the two. So they bridge from here, what you have on the left side, some of the, the known things about observational studies, where we have to control for confounding, where the treatment rule may be unclear, versus on the right side, where we have more things related to RCTs, where we talk about often short follow-up time and highly selected smaller samples. So quasi-experimental designs kind of bridge between the two. And I want to talk very briefly about those two things on the RCT side, which is the insufficient follow-up first. And this is, as you know, although they're gold standard, this is a common limitation of most RCTs, and often it's due to cost, right? So it's really difficult sometimes to study outcomes such as dementia because they need a long follow-up to have enough events and have enough power to conduct analyses. The other thing is and a lot of times RCTs have stopped because there was a beneficial effect, right? So they couldn't, for one example is Sprint Mind, if you want, where they had to stop earlier because of a protective, because of a benefit that they found on the primary outcome, which was cardiovascular disease. Another issue with another challenge in RCTs is the selection bias in the study population. As you know, RCTs often have a very rigorous and strict selection criteria, and so you end up with a highly selected and smaller samples than the general population. And to showcase that highly selected smaller sample, I just wanted to kind of briefly illustrate how the PROSPER selection and study sampling happened, right? So this is a schematic illustrating older adults who were enrolled in PROSPER. So originally, a total of 23,000, more than 23,000 were screened for eligibility in PROSPER, but only 24% were eligible and accepted to participate, right? And so you end up with 24%, around 6,000, but at the end, were actually analyzed, right? So 5,800 were randomized, but then 61% were actually analyzed. So this is just one example of how RCTs could have very highly selected study populations. So that brings me to our research question, really. So to reiterate, for proof of concept purposes, in this paper and presentation, our goal was to investigate whether RDD could really help us replicate the known causal effect of statin use on MI on a myocardial infarction in an observational setting. And I say the known causal effect is because we know the truth, right? So here in this case, we know it's already well known from randomized trials that MI is protected, that statins is protective against MI. For example, briefly, a large meta-analysis of randomized trials has shown about a relative risk of 0.76 for fatal and non-fatal coronary heart disease. PROSPER itself, they have shown, which was among 72 to 80 years old, has shown a hazard ratio of myocardial infarction of 0.81. So those are kind of the point estimates that we are looking for. And these are what we call the truth regarding the effect of statin and MI. So we know those estimates from the trial. Again, in this case, in this paper, we are using really MI as a positive control outcome because our goal is to calibrate and validate the use of this method for the study of statin treatment effects more generally. And specifically, we're interested in dementia. So we want to calibrate it and then use it to go ahead and look at the relationship with dementia, for which we don't know the true causal effect from trials. And we've seen this mixed findings. All right, so I'll begin with some of the methods. So for this research question, we use the Health Improvement Network, which many of you might be familiar with because it's based in the UK. It's a de-identified primary electronic health record database in the UK. And Sebastian touched a little bit upon this, but in 2008, as you know, the National Institute for Health and Care Excellence in the UK recommended that statins are indicated for the primary prevention of CVD if a patient's 10-year CVD risk score is greater than or equal to 20%. So if your CVD risk score is greater or equal to 20%, then you're recommended to be prescribed statins. So that was a national guideline. So for us, this national level guideline provides this ideal setting for an RDD because the treatment, which is statins, is going to be given or withheld only according to that CVD risk score. This is just very hypothetical. Again, I don't need to show nice figures because Sebastian has shown a lot of figures here. But again, in this case, what I want to point out to is a couple things, is that First, we have the CVD risk score, which is kind of our instrument. It has a cutoff of 20 that is set by the guideline, this national guideline, and we're going to be looking at people above and below it. Now, how much above and how much below it is going to depend on this concept of bandwidth, and that's the concept that he talked about that is very important. It's kind of, you want to think about it as your neighborhood. How much can I go outside of that 20%? And again, as Sebastian mentioned, it's kind of this balance between precision and bias. The closer you're going to be to 20th, the more precise, the less biased, but then the precision might be less and less, right? So it's kind of that kind of balance between the two of them. So we have to choose a bandwidth. We rely on that cutoff, and then we're going to be looking at people above and below that cutoff. So we use RD to estimate the causal effect of statins on MI among those who are 65 plus and who have a recorded CVD risk score, right? So we're using this de-identified data, electronic health record data. We have a recorded CVD risk score. So we use that recorded CVD risk score between 2008 and 2011. So that's kind of our enrollment period. We had to set an enrollment period as if we're doing a trial. We set it a little bit longer because the national guidelines started in 2008. So we wanted to give enough window for that guideline to be really in effect. So we chose that window. And then in this case, our running variable is that CVD risk score, which goes from 0 to 100. And then the cutoff is 20% that is set by the guideline. And then our treatment is really whether you're above or below the cutoff. Are you going to be expected to be prescribed statins versus not? We had done certain exclusions, and I'll show you some of them, but basically one of the main ones was that we excluded those who had statin prescriptions 2 years prior to their CVD risk score assessment, and also excluded those with a history of CVD, right? Because if you have a history of CVD, you're not supposed to be given a CVD risk score. So we had made those exclusions, and we also did the 2-year washout period, again, to mimic what happens in a trial. This is a little bit of a busy slide, but it shows you really our thought process in those exclusion criteria. So we focus on those 65 plus, whether they were enrolled in 2009, 10, or 11. They had to have a CVD risk score in that enrollment period. So that gave us about 175,234 participants. And then they had a CVD risk score. Here, I have to move my screen. Okay, so they have a CVD risk score anytime in that enrollment period, and they were 65 plus at that time. They were also registered in the clinic at least for 6 months prior to their CVD risk score, and the reason for that, we wanted to have those pre-treatment or those kind of confounders that we wanted to look at them. We wanted to have them happen before any statin prescription, so we wanted them to be in the system before that. They did not, we had this washout period. Also, we had some, we excluded some people with regard to the death date that occurred on or after CVD risk score. And we also excluded people who had a history of CVD. So they had to be without a history of CVD. And so we ended up with a total of 49,242. So you can think of how much the EHR data is large. With our criteria, we started with 175,000, and then we ended up with 49,000 plus or take. Okay, just gonna move this back. All right. Sorry. Okay, so just to give you an idea, when we looked at the CVD risk score in the EHR data, more than 80% of them were based on the Framingham risk score, which might be familiar to you. It's one of the most commonly used CVD risk scores. The rest were based on the Q-risk or the Q-risk-2. So we used whichever one was available. Statin prescription is recorded in the database using codes from the UK Pricing Authority. Statin initiation was defined as a new prescription in a patient with no prescription in the past 2 years, right? So we had to exclude people who had prescription in the past 2 years. So we're looking at new users. the primary outcome of interest was fatal and non-fatal MI. And these, for these, we use the Reed Court system, which again, you may be familiar with being in the UK, which maps onto ICD codes. So we had all those listed, and we had a kind of a protocol of going through these ICD codes. So in a way, we really used that motor vehicle. We used our MI as the positive control, as the positive outcome that we're interested in. But I also want to note that we used motor vehicle accidents in addition to MI, and we used MVA basically to be as a negative control outcome, right? There is no reason for us to believe that there should be a relationship between, a causal relationship between statins and MVA. And so we wanted to have that to just, kind of a validation. So we had MVA as a negative control outcome and MI as our positive outcome. Okay. And one more thing also, we did not only just use RD, but we also compared our findings from RD to those from a propensity matched analysis, and also to one from a conventional confounder adjusted analysis, right? So we kind of compared them to more traditional methods and to see what would the results look like. So let's check some of the results. All right, so as Sebastian has mentioned, like bandwidth selection is one of the most important things. So we kind of started with, let me just 1 second. Something. All right, I'm just gonna share screen again, sorry. Okay, here it is. Okay, so we first started with, we wanted to make sure we know what bandwidth we're working with. So we did this bandwidth calibration. And here what you see in front of you is that bandwidth calibration illustrating the bandwidth on the x-axis right here. So this is a bandwidth of 4, 6, 8, and 10. And a hazard ratio for MI on the left hand. So this is MI within 5 years, and this is MVA within 10 years. And I'll go over why 5 and why 10, but that's for now. I just want to show you our bandwidth selection. So what does it mean 4 and 6 and 8 or 10? Remember, our cutoff was 20. And so when we talk about a bandwidth of 4, so we're saying we're going 20 plus 4 and 20 minus 4. So that's our bandwidth is like 4 points. And a bandwidth of 6, 8, and 10, etc. So you can see very clearly from here that for MI, we had, for both of them, we had 49,000, about 49,000 eligible patients. We had a total of 575 MI cases in 5 years. That's about 1.2%. And the algorithm, which Sebastian talked about, selected a bandwidth of 5. So it selected something around here. This is a bandwidth of 5 right here. And so we observed that the hazard ratio, in addition to that, so we went with that bandwidth. In addition to that, we observed that the hazard ratio for MI was kind of robust and relatively the same across a range of bandwidth. As you can see, like it didn't move so much regardless of the bandwidth. And our choice of 5 years was mostly based on prior RCTs, which were on average about 5 years. So that's kind of what happened for MI. So we chose a bandwidth of 5. For MVA, to note that among the 49,000 eligible patients, we only had about 160 events happening in 5 years. However, we had 213 within 10 years. This was still low. Again, the algorithm selected a bandwidth of 5, but given the low MVA event rate and the fact that the effect sizes or the effect estimates were less variable when we looked at 10 years, as you can imagine, versus 5 years when we had only 0.3% events, then we used the 10 years. So we selected the 10 years for the MVA. That's the main reason we had such a low event rate for MVA. And we selected a bandwidth of 5 because that was the one that was selected. And actually it was much more variable, that that here, the upper and the lower, these are the upper and the lower limits, and they were much for the hazard ratio, and they were much more variable in the 5-year. So that's why, again, we went with the 10-year. All right. Another important thing is looking at adherence. To what extent there is adherence to statin treatment in those who are below and above that cutoff, right? Ideally, what you want to see is you want to see among those who are below the cutoff, 0% of them are using statins. And among those who are above the cutoff, you want to see 100% of them are using, but that's not usually the case in real life. And so you want to see differences. So what we see here is that among those 21,326 patients that we have below the 20% cutoff, we see about 11.9% of them initiated statins by the end of our enrollment period, which is 2011, right? When we look among the 27,000 plus patients who are above the 20% cutoff, we see 35.4% initiated statins. So there is a jump, there is a difference between the two. That difference for us was okay at the moment. It could be sometimes worse in real life data. So we were happy at least to have, you know, that kind of compliance above and below the cutoff. All right, this is here also another typical thing that you want to look when you do an RD design analysis. You want to look at that balance of key confounders. So we were limited in the number of potential covariates that we can use because, again, we're using EHR data, right? So the pros of it is that you have an access to a large sample size, diverse, but then on the other hand, you may not have a lot of covariates that you're interested in may not be collected, right? So we have a limited set of covariates. And here the main idea is to compare how does that distribution of that covariates is above and below the cutoff. You want them in that bandwidth that you selected, you want to be no difference, right? So you want to have exchangeability. And here you could see from the p-value that we achieved that balance of key confounders below and above that cutoff of 20%. Now, as I mentioned, we also not only did RD here, but we wanted it to compare it to propensity score matching. So we created a propensity score, which is basically the same thing. You're saying, what is the probability of using statin, right? And so you build that model, we build it using the same covariates that are listed here, and we create that probability and we match on that probability. And so here, this is again showing covariate balance. This is prior to matching. The red dots and the blue dots are post-matching. And you could see that most of them are closer to 0, what you want to see. But again, you could see that there's a little bit more of them that are a little away from the 0. All right, so I'll go to the main part of the results section, which is what did we find? So this here is to really a comparison of the estimates for the association of statin use with incident MI over 5 years based on the different analytical approaches. So using the RD model, first we did a sex age adjusted model, and then we did a fully adjusted model where we added all these covariates that I listed. And again, as Sebastian has mentioned earlier, in an RD, you don't even have to adjust for these confounders because you have balance, but if you have them, you could adjust for them, could help with the noise. So we did that. And what we find a hazard ratio of 0.80 or 0.79, quite similar. The confidence interval is quite large, so we don't reach statistical significance. Our results are inconclusive, but our point estimate is about 0.80. And just to remind you, these are quite similar to the point estimate that I just mentioned earlier from the meta-analysis or from Prosper or the other trial, the main trials, where they also found hazard ratios in those kind of region, 0.76 to 0.80. So we were very happy that at least that we found that similar point estimate, although our precision wasn't great. Now next, is the results from comparing the RD model to the traditional Cox model and then to the Cox model where we matched, in our matched subset. And you could see in the matched subset, we have much less, right, subjects. than in the traditional Cox model, where we used all the 49,000. And so really clearly what you can see is that we find a hazard ratio that is totally in the other direction. We find a hazard ratio of 2.6 to 2.5 in the traditional Cox model, and also in the PS matched, we find a hazard ratio of around 2.4. And they were statistically significant. So there were definitely an obvious discrepancy in the results between our RD model and the traditional models. All right. So that brings me to some conclusions that I would like to make based on those results. So the RDD, as you can see, resulted in a relative risk point estimate that was similar to those from randomized controlled trials in direction and in magnitude, whereas matching did not. The estimate for the association of statin use and injuries, right, from MVA as a negative control outcome was also close to the null. I don't think I showed that. I should have added slide, but we found almost a null relationship. So that was good in the RD model, which because it was our negative control outcome. Based on our results, we find that RD appeared to be superior to propensity score matching in replicating the known protective association of statins and MI, and saying that at least within the context of EHR data, right? So we are working within the context of EHR data, and in that context, we find that RD to be superior to matching, to propensity score matching or traditional confounder adjusted methods. Our study provides a real-world application of RDD, leveraging this national guideline on wider statin use in the UK. And so it appears really promising and a practical approach to adjust for measured as well as unmeasured confounders in observational settings. Finally, also our study extends prior methodological investigations in the thin database using RD, and a lot of work was done really by, if I say their names correctly, like Gianelletti and O'Keefe, who have done a lot of work, especially looking at statins and low density lipoproteins. And they found, using the 20% cutoff as well, and they found results validating the use of RD vis-a-vis RCTs. However, there are a couple of things to consider. Despite these exciting yet cautious results, a major challenge was that event rates were lower than in trials, right? So our event rates of MI were much lower than those you find usually in trials. But this is, again, really expected because by design in trial, they oversample for high-risk populations. So you have more events happening, you have much more power, much more precision, versus here, this is real-world data, and you have less events. So precision was limited in our case. Now, I understand correctly from Sebastian that this is something we could be working on, working on precision, but again, it was beyond the scope of our grant, our paper. It will take a lot of work, but this is something we're definitely interested in, how to make precision better, even in the absence of like a huge number of events. We also used a sharp RD. So this is like an intent to treat analysis, right? We didn't look at actual treatment. We just used that guideline and assumed if you're above, you're treated. If you're below, you're untreated. We know based on the compliance data I showed that many deviated from that rule. And so the next step is that we need to incorporate what he talked about, which is fuzzy RD, right? But again, fuzzy RD and Cox models right now, those two together, they're not available. And so this is an ongoing area for methods development. We hope that we can then apply in the future Cox models within a fuzzy RD framework. Also, it's important to note that although we were excited to have a big sample size, EHR data are subject to misclassification bias and a measurement error. We also did not have individual level data of socioeconomic status, which could be an important confounder. We did not have individual level education, but we used the Townsend score, which you all may know, it's a census level variable. And some of the work that Carol has done has shown a great correlation with education level, but still it would be obviously a nice thing to have individual level SES, and maybe future work, we need to do some bias analyses to see to what extent our results might be influenced by, some misclassifications going on. The study was conducted in the UK. We work in the US. Often a question, so why would we care? This is done in the UK. And I say, well, most trials that I show you are done in the UK. But also there have been a lot of studies that showed that there's no reason to believe that the biological effect of statins would vary by population or geography. And so that is another reason to kind of be happy about being able to do a robust analysis within EHR data in the UK. And with that, I think I would just like to, spend 1 minute acknowledging the co-authors on this work. This was the effort of 2+ years. And this work was funded by NIA. And we had a wonderful program officer who really believed in this work and supported us, Dr. Anderson. And so I just want to acknowledge everyone here, and the MPI on this grant as well with us, Michelle Auden. And with that, I just want to thank you all for, listening to this talk, and we're happy to really just discuss it with you.
Thanks very much to both of you for such a clear presentation of really what is quite a complicated approach to analysis, but so important in terms of trying to think creatively beyond the challenges or the limitations of usual observational data. So I wonder if you could stop sharing, Adina, and then we can see people. So we are at 3:15, and I think for many people this is the slot that will have been in their diary. So if you have to leave the seminar, please just slip away. But there is, I think we can have 1/4 an hour to kind of address any questions that you might want to ask. We do have analysts on the call, so to people who have done lots of analysis in the past. So I'd really like to hear from them, or anybody who's done this kind of analysis and wanted to try to move beyond the limitations of observational data. So do we have any? I haven't seen any questions coming in. One thing that struck me that I wanted to ask was about death. Do you think that because you excluded some people who died, but then you had MI mortality as an outcome as well, and I just wanted to ask you about that. Whether there were any complications there, and Sebastian also mentioned survival.
Yeah, no, I think what we excluded is people who mistakenly probably had a CVD risk score, but then they were mentioned to have died before their CVD risk score. So these are people that we have to exclude.
That's a data anomaly. Yes.
Exactly. So that's what I meant. So we had to exclude like maybe a few hundred people who just didn't seem right, that they were dead and still be seen or something like that. So that's what I meant.
Yeah, okay. So please put your hand up or put your camera on if you would like to ask a question. We could see a thank you there from Lena, who I think has had to leave. Another question that I had was, do you have a data set to be able to look at the bias that's introduced by people who actually have a CVD score? I mean, in a pragmatic way, actually, it's the people who a GP would be thinking about prescribing for, and then therefore they would do the score in order to have that communication with the patient. But did you look at cardiovascular mortality in those who hadn't got a CVD score and see what proportion of the, if you like, the burden of cardiovascular mortality in the population is potentially reduced by statin, by that 0.8 effect of statins?
This is a great idea, Carol. We had not kind of, yeah, it would be very interesting to look at the cardiovascular mortality in those who had not had a CPDR score. We did not look at that, but it could be good to look at it.
Yeah. Okay, so I mean, I should have picked that up. Obviously, I've got familiarity with the work, but it would be nice to do a kind of wraparound public health piece, which could be quite short, actually. We've got quite a few people. Oh, Ernest, are you going to ask a question? Great.
Yes, please.
Thank you. Go ahead.
Yeah, thank you for your presentation, and they really look great. But my concern was in terms of the treatment. We expect the patients to their health to be improved or to exacerbate. So how did you ignore the treatment of confounding when they are time varying covariates?
Right. So you're mostly worried about time varying covariates, like things are changing.
Yes,
like their covariates could be changing, right? So we did at one time, right? We had an enrollment, we had covariates pre-enrollment, like kind of what you do in an RCT. And we did not account for time varying covariates. We actually, this is probably part of this dynamic RD models that could be incorporated, but we haven't definitely not gone that route. It's probably way beyond what we wanted to do at first. But yeah, that's
a great comment. So we basically relied on this idea of the RD, right? So that you expect individuals to be comparable, those who are close but in different sides of the treatment. And what we show is basically that we have balance in the variables that we observe. But yes, here is non-standard in the survival aspect, but also in the dynamic aspect. I think that you bring a good point. That's something else that I think we can, and we would like to extend the model at some point, right? So people could have multiple visits to the doctor, and they might have different trajectories basically after the first one. So that's something. As the most we are concerned is for addressing with these covariates we included that Adina mentioned. But yes, we could be, there is definitely room for more things to be more careful about. Yeah.
Right. Thank you.
Thanks for that question. So do we have any other questions from the floor? I think I don't see any coming in. Oh, wait a minute, here we are, Cherry. Thank you, Cherry. Yeah. So you have individual, do you want to ask the question, Cherry? Do you want to just put your camera on if you can and just say where you come from? Sorry, I should have said Ernest is from AstraZeneca in Cambridge.
I don't have the facilities right now, she says, Cherry.
Oh, yes. Okay, so if you could, yeah, the individual.
So you have individual information regarding age and sex, but not the other SES. Yes. So yes, that's correct. Exactly that. And especially we would have liked to have education, as I said. So yeah, that's one of the challenges of using EHR data. You're just limited by what you have there. And usually they don't collect much individual level data that are social determinants. Yeah.
Yeah, that's a major challenge with these routine data sets, is the limited amount of personal information that there is. Yeah, and there's not much you can do to, unless, yeah, I mean, locality level deprivation is used for, yeah. Cherry's got a further follow-up question. So what's the covariate balance on the slide? And what's the p-value?
Yeah, let me just show that slide and here. Okay, so I don't know if so. Let me see her question again. So this is, and maybe Sebastian, if you want to say something exactly about what this showing in terms of coefficient and everything.
Yeah. So basically, what we are doing here is looking at the balance of the covariates between treatment and control, but not the usual way, but in an RD way. So we are changing the outcome. Now then the outcome will be each of these covariates, one at a time, right? And then we see that locally, these two groups, the treatment and control, or being left and right to the cutoff, they look the same. So we would like to see that they are similar, right? So we would like to see high P values here, so that
yeah. So for example, for age, Jerry, like we have 18,718, we have 9,670 and 9,000 above and below the cutoff. This is N below and above the cutoff. And you could see the coefficient here is basically the value above minus below the cutoff or something like that, right? And so this is the coefficient with the confidence interval, and that's the p-value. And so that's how you kind of get a sense to what extent that, you want them to be the coefficient small, obviously, so that, they're almost the same. And that's how that p-value is about. Does that make sense? I hope so.
Yeah.
I think it makes, I would imagine it makes sense. Yeah, Jerry says great. But the variable number is where the data is giving us a sense of where the data, well, the kind of gaps in data, is that right?
Which one? Sorry, Carol?
The variable number. So you've only got 4,509, unless I'm reading this wrong. That suggests that you've only got marital status in a proportion of those.
Yes. Okay. So exactly. So the other thing is that we had a lot of variables where we had some missingness, right? And so for some of those, we kind of actually created an indicator variable so we don't drop it for missingness. And so what I'm showing you here is that for those not missing, which was about 4,500, right? So that's the other challenge for EHR data. Something like marital status, which you take for granted in cohort studies, it's always asked, almost none missing. Here you have a lot of missingness.
Yeah.
And so yes, that shows you like that there were missingness. Yeah.
Thanks for explaining that. Right, great. So any other questions lots of thanks coming in. People obviously really enjoyed it and found it very clear. Any other queries or questions? There were quite a lot of formulae. But I think that lots of food for thought for folk. If there's not any more questions.
Yes, you have our email, so always we would be happy to connect.
Okay, thanks. Yeah,
yes.
People might want to digest sort of sense. So yes, well, thank thank our folk and applaud them. And it's really great to have done this seminar, and and it's good to collaborate, clearly. And thank you to Karen for working on all the logistics, which seems very smooth. Thank you for giving up your time.
Yes.
All of you, but particularly our speakers.
Yeah. Yeah, and it would be great. We can talk later, Carol, because I do think it's like something that worth like a small opinion about, like kind of the public health relevance.
Sort of the bigger picture. Yeah. Okay. Will do.
But thank you so much for inviting us. It was really nice to see everyone there, and thanks for the engaging talk. It was really nice. So we appreciate it.
Thank you. And so have a nice rest of your day.
Thank you. Thank you so much.
Thank you so much. Very nice to meet you.